Welcome, JAT Chat, presented by the Journal of Athletic Training, the official journal of the National Athletic Trainers Association. I'm Dr. Kara Radzak, an associate professor in the School of Integrated Health Sciences at the University of Nevada, Las Vegas, and your host for today. Today, I'm joined by Dr. Alan Needle. He is the lead author on a recently published manuscript, Transcranial Direct Current Stimulation over the Motor or Frontal Cortex in Patients with Chronic Ankle Instability, in the Journal of Athletic Training. Dr. Needle is a professor in the Department of Kinesiology and the Department of Rehabilitation Sciences in Appalachian State University, where he's been since 2013. His research focuses on central nervous system adaptations that occur after ligamentous injury, with a focus on clinical assessment techniques and neuromodulatory interventions to identify and treat these changes. Thank you so much for joining me today, Dr. Needle.
Happy to be here.
So I think the first thing that we need to kind of set the stage with is, Alan, can you give us basic introduction in what is transcranial direct current stimulation?
All right. So the name on this one is kind of telling us what it does. Transcranial direct current. It's a direct current applied to the brain. So as far as technology goes, this is identical to iontophoresis, which uses a direct current. But the difference is, instead of applying this through the skin over a part of your body, we're doing this over the skull. So transcranial and targeting parts of the brain. What we use are these sponge electrodes that we soak with a little bit of saline. It's not a high enough current to conjure images of the Green Mile, but it is enough to make its way into the brain. And anytime we have motor learning occurring, that motor learning is just a flow of ions coming across to help the development of new synapses and create some long-term potentiation, which is learning. tDCS is a tool that makes that process easier. It starts to shift the membrane polarity. And if I then do some exercises or do things to reinforce it, in theory, it should make those new synapses form easier and therefore help you learn easier.
So what prompted you to pair this tDCS treatment with chronic ankle instability in particular?
So this goes back about 8 or 9 years, if I'm remembering right. At this time, we were putting out a lot of research that was looking at all these changes in cortical excitability and these changes in EEG in patients with joint instability, which included ACL individuals and patients with ACL tears and those with chronic ankle instability. And we were seeing these differences. The question that I kept getting every time I presented it, especially to any clinical conference, was, so what? Right? What do I do with this information? Why do I care about this cortical excitability? And it was a very fair question. I could explain maybe why it would impact somebody's function, but nobody cares unless there's something you could do about it. And so what we started to look into is what treatments could change these things like cortical excitability. Most of my career has been based on looking at these different neurophysiologic measurements, and I've always joked that I basically just steal as many ideas as I can or adapt as many ideas as I can from stroke, cerebral palsy, Parkinson's disease, these upper motor neuron pathologies. And that's kind of where the tDCS came in, is that this was a intervention that's being used in some of these populations. But interestingly, when we look at the use of tDCS for motor function, because it's used for a wide range of things, it's used as a treatment for depression, anxiety, ADHD. But when we look at trying to improve motor function, the results were kind of all over the place. And my theory on that was that we weren't seeing good results because it was either being done on healthy individuals who had normal motor function and didn't really need this little extra boost, or it was being done on those with stroke or cerebral palsy, where there's an actual structural change in the brain that the tDCS isn't enough to overcome. And given that we were describing chronic ankle instability as this remapping of the brain after an injury, we figured, since that's functional, not structural, this might be something that could benefit that population. And so we started to look into that.
So give us an overview of kind of the methodology. You looked at using it in the motor cortex versus the frontal cortex and also a sham condition. And then you paired this with a rehab program. So give us some background on why you chose these different groups, these interventions.
Yeah, so this was a follow-up to a previous study that we had published back in 2020 in Medicine, Science, and Sport and Exercise, where we looked at eccentric exercise and we did tDCS over the motor cortex over 4 weeks, and we saw improvements in a lot of variables, things that included neurophysiologic function like cortical excitability, things that included performance like balance measures, and things that included patient reported outcomes like perceived disablement. This study that we recently published was following up on that with a couple different important changes, one of which was the rehab protocol. When we're doing tDCS, it makes the brain more plastic, but we need to do something to take advantage of that plasticity. It's wanting to change, but we need to give it something to change around. So when we did the first study, we did an eccentric strengthening protocol that involved using an isokinetic dynamometer, very well controlled, great for research, not very clinically applicable. So it proved our concept decently, but not something a clinician could use. So part of this was we used a protocol that was meant to emulate what you might be able to do in a clinic with a focus on some motor planning. The other part of that is that we were doing tDCS in a couple different locations. What we had previously done was the motor cortex, with our theory being, all right, if we do it over the motor cortex, you're going to get better at activating the muscles controlled by the motor cortex or the muscles you're using during that rehab. But again, looking at what we're seeing in some of these other populations, and one of my co-authors on this paper, Jared Skinner, does research looking at Parkinson's disease in older adults using frontal cortex stimulation. And the target here is the part of the brain that's the dorsolateral prefrontal cortex. And the idea is that it helps with motor planning. So it's not just about motor execution like the motor cortex, it's about your actual planning deficits and what strategies you take to handle especially complex environments. So there's some evidence out there that shows how motor planning is affected in people with chronic ankle instability and those following ACL reconstruction. So we said, all right, let's compare motor cortex versus frontal cortex. And then let's go ahead and figure out something that would work with them. When we were forming this study, originally I had this motor intervention for the motor group and this planning intervention for the frontal group. And then we ended up we realized that that was not a very good design, at least from a blinding perspective. So we decided to come up with an intervention that combined these, something that involved motor recruitment, things that were motor demanding, while also being taxing on your motor planning. So we created this complex rehab that was based on obstacle course walking, choice reaction times, and some complex stepping tasks.
So you really were getting to what, like we are all trying to achieve from a clinical standpoint of integrating and getting them back to sport or physical activity. So take us through kind of what you saw and how do you interpret one of the interesting findings that you found improvements regardless of if they received the sham or the actual intervention?
And this is, ironically, I just said we changed our protocol to make it a little bit tighter, and I think that kind of impacted some of our results, and I can get to that in a little bit. But our results basically showed improvements, especially in our patient-reported outcome measures over the course of this intervention. So we measured individuals. We did a 4-week intervention where they came in twice a week to get this rehab protocol with instrumented electrical stim over their head. To them, it feels like a little itch. We had 2 groups that got an active current and 1 group that got what's known as a sham current, where the stimulator was turned on for a minute and kind of once they accommodate, it gets turned off. This is all automated for us, so we didn't have to worry about blinding. We just punch in a 6-digit code that was blinded to us or randomized to us, and we were able to not know what our patients were getting. But we measured these individuals at the halfway point, 2 weeks, 4 weeks when they were done, and a retention point 2 weeks after that. And we saw patient-reported outcome measures got better across all groups. We did not see we saw some improvements in performance. Some of our hopping measures got better. We didn't see a lot of evidence of neurophysiologic improvements. That's from looking at cortical excitability, and that is from looking at EMG activity, muscle activation. So we're seeing an improvement across all groups with this motor planning intervention that wasn't necessarily tied to our neurophysiologic changes or to this neurophysiologic intervention that we were trying to do. So I think you asked me to explain why we think we saw those results. Was that what you were getting at
Yeah.
there? Okay.
Yeah. What do you think's going on here?
Yeah. So, there's two thoughts that we had as we kind of looked at this. One of them is that we didn't quite see an effective intervention here. We did see improvements in our patient reported outcome measures, but the magnitude of those changes were on the borderline of what would be considered clinically meaningful. So, on the one hand, we could say that maybe this intervention didn't do a lot. We could also say that maybe this tDCS didn't work, right? Because everybody got better regardless of whether they got tDCS. That's something I put the most thought into because what I think is that we ended up shooting for the middle. We tried to come up with a rehab plan that used motor execution and motor planning. And because of that, it wasn't enough of a stimulus for either one. It's if we wanted that motor cortex stim to work, which we've seen in previous research, we needed to do demanding motor exercise, right? Eccentric strengthening like we did before. That prefrontal cortex stim, that might work, but maybe I need to do things that are a little more mental, things that are a little bit more about mental imagery or action observation. These are some things we've done with these other populations. But the other side of this, and I'll give credit a lot of this to another one of my co-authors, Jennifer Howard, who, looked at this and is like, we had a relatively high functioning group coming in. They definitely had chronic ankle instability. We have no doubt about that, but they're functioning with it. And they're improving still, even though it's not the largest magnitude of improvement that we'd hope to see, they're getting better. And this might reflect a problem that we see, especially with chronic ankle instability of individuals that really don't get to that high-end rehab that we know that they need. So a lot of people, right, once you're back and you no longer have pain and you feel strong enough, you're going to stop rehab and go back about your life. We all know as clinicians, we struggle to get those people back in the AT room to do stuff. So maybe this is some evidence that once we get them going to the higher end of things, we can really have some meaningful improvements when we start doing this motor planning interventions. I don't think we did anything novel in our motor planning intervention. I mean, I've been in plenty of AT rooms that are doing these obstacle courses and these choice reactions. So depending on how that looks, it might be novel or, it's basically just things that require decision making.
So, what do you think is the future for this tDCS in its potential use within an athletic or a physically active population? Because, like you mentioned, right, that most of this is being used in Parkinson's, stroke. Where are you going from here?
So that is a very interesting thing because a couple papers that we published recently. So as far as we're aware, we're the first group back in 2020 that looked at tDCS in individuals with musculoskeletal injury with chronic ankle instability. La- I, Last year, we published a paper, and at the time in JAT that talked and gave a little bit of a review of this, and we saw that there were at that point two papers published, including ours in chronic ankle instability, one in acute ankle sprain, and two in those with ACL injury. And I was helping somebody with a paper recently, and I was looking into what the evidence was. And I found that since a year ago, there have now been 13 papers that just look at tDCS and chronic ankle instability alone. So the amount of evidence that's emerging in this area is growing at an alarming rate, alarmingly good, but still, it's impressive to see things coming out that quickly on this topic. And seeing through the noise is a little bit interesting. When we start to see a lot of these papers are showing maybe no changes or small changes. There's another type of tDCS that's out there known as high density tDCS or HD tDCS. The papers that have been using that have been seeing some larger changes. And then I think we're going to start seeing a lot more of these different approaches to using tDCS, so these different targets. And I think what it comes down to is that there's a lot of different parameters to play with that we're going to start to see emerging, maybe looking at some efficacy, but we can see things about what is the dosage response. In other words, how many times do I have to do this and how much rehab do I have to do to get somebody back? What is the right target in the brain, right? We did motor cortex versus frontal cortex. Other papers have looked at the supplementary motor area. I recently saw a single session design that looked at the cerebellum. So there's a lot of different places in your brain that you could put the stimulation. And there's a lot of different exercises you could pair with it. Like we mentioned, a motor intervention might work, like eccentrics might work better for the motor cortex, whereas maybe mental imagery might work better for the frontal cortex. And I think that's where we're going to start to see a lot of the research go. And hopefully that is kind of how it carries into the clinical setting. And if it were my prediction, I think we're going to start to see some more targeted looking at individual impairments and let's choose the right type of stimulation to get there.
So, a lot of times, especially in athletics, right, the interventions move faster than the research can. So, if there are people out there that are like looking at this as a potential intervention to give them that like little like 0.1, 0.2% edge, right? That a lot of programs are wanting, like what are some things that you would say to a sports medicine program that's playing around with the idea of do we bring this into our clinic?
So that's a really great question. One of the factors that we're seeing, there's this line of do we need it, right? I actually, 10, I mentioned I've been working on this for 7 or 8 years, but I think it was 10 years ago. An article came out I saw about the Golden State Warriors using a tDCS based device as part of their training. And me as somebody who studies a fair amount of neurophysiology was like, well, that makes no sense at all. Mostly because our brain doesn't need to do a whole lot for a lot of just general strength and conditioning, right? It would be more helpful if we're doing complex motor tasks, but most of our walking, right, we don't need a lot of brain activity to do that. But we've been seeing over the past, 15 years now is that individuals with joint instability do need a lot more of their brain going. Now, as so that's part of the tDCS side, but there's another thing that you kind of asked here of like getting that extra 1%. And a lot of this comes to we need to think I do think that anybody that's working a sports medicine practice and is regularly dealing with people, especially with recurrent injury, needs to be thinking about how the nervous system has changed. tDCS is one tool with the potential to modify the nervous system. And that's really how I've been treating it. It is one tool out there and it's something that pairs well with some of the other tools we can use. But there's a lot of other interventions that have specific effects the nervous system. It's what we've been calling neuromodulatory interventions. We published a paper a year ago in JAT that we proposed this concept of neurotargeted ankle rehabilitation strategies that looks at trying to get at, what are the neuromodulatory interventions for the motor side of things, things like eccentrics and plyometrics. What are the neuromodulatory things for the sensory part of things? That's maybe joint moves, maybe massage, maybe electrical stimulation. What are the things that get you psychologically ready from a neuromodulatory perspective? This is a brand new area that, we don't know a lot about, but perhaps mental imagery. And then what are the things that bring it all together with tDCS being one of those possible tools? That was a tough question. I hope I answered that one all right.
I mean, that's the thing is like, how do we translate these things that are happening into the lab, into the clinic where, yeah, the clinic moves so fast, right?
Yeah, and especially with tDCS, we have a lot of different we're using a clinical trial stimulator that allows us to do a double blind, but,
Mm.
I've done some presentations. I've done presentations at NATA, a learning lab, and there are commercial devices out there that costs between $1 and $500. They're usually marketed for non-medical purposes. They're marketed to help improve attention and things like that, although I've been recently seeing some portable devices that do target the motor cortex coming out. So, this is a pretty accessible technology, more so than I think many athletic trainers and sports medicine practitioners would give it credit for.
And a lot of times we get asked by the athletes, right? It's the athletes that bring up what they saw on TikTok, right?
Yep.
So, I mean, we kind of danced around this, but neuroplasticity is such a buzzword in sports medicine and athletic training. So, what should athletic trainers understand about how the brain adapts to musculoskeletal injuries, and why does this matter during rehab and rehab design?
Yeah, I think, this is, I think, the question to be asking. It's really been the question that's driven me for the past 10 to 15 years of, you know, this is, we've turned to neuroplasticity as a way to possibly explain what is causing these recurrent injuries. It's to explain our own frustrations. We all have been in these situations that we rehab individuals. They look great. They are so good. They are at peak performance. And then 3 weeks, 3 months, 3 years later, they're re injuring themselves. And, we've turned to, okay, we got all of their impairments handled. We got their strength back, range of motion back, proprioception back. Everything is looking so good. And potentially the explanation here is that it's something we can't see, and it's something that's really hard for a clinician to measure. And that's this change in nervous system function, this neuroplasticity. We published a paper, myself, Adam Lepley, and Dusty Grooms back in 2017 that put a model out there. And then last year in that JAT paper, I updated a little bit to talk about what is actually happening as we move from this acute injury to this chronic dysfunction, from a ligament sprain to joint instability. And it helps to explain a lot. It helps to explain why somebody is able to look functional and look like they're have smooth movement and are never going to hurt themselves when we look at them in the clinic, and why they struggle in the real world. And I think that's why we have such an emphasis on the neuromodulatory side of things now, because we mentioned that we saw these relatively small improvements in this current study using this motor planning, but we didn't see changes with the neurophysiology. So that leads me to ask the question of, like, did we see durable changes? Did we see changes that are going to last when they go out into the real world? When we compare it to that study we did a few years back that did motor cortex stim with eccentric strengthening, we saw that there was an improvement in cortical excitability, and that improvement was tied to better muscle activation when they balance, and that was tied to less disablement. And we're able to see that if we can fix that source, that unseen source that as clinicians, we're not that attuned to generally, right? We can't see how somebody's brains are functioning. We could infer plenty of times, or sometimes we can question if their brain's functioning at all. But we are not necessarily able to see, is that motor cortex firing? So to just think about what you could do to get things firing might be that key to unlock and prevent or reduce the risk of recurrent injuries.
So, if an athletic trainer is wanting to kind of take a first step into this area, what do you recommend for them?
So, as a first step, the biggest thing that I've been recommending is just some critical thinking techniques to ask yourself, is what I'm doing going to change the nervous system? Or everything's going to change the nervous system, right? It's adapting to everything in your life, but how is it going to change the nervous system, right? What can I do to make things more intentional about it? Right? Sometimes that's as simple as, instead of just having somebody do single leg balance, I'm going to force them to dual task while single leg balancing. So we're engaging these extraneous areas of the brain so that they're not available to help with simple movement, and therefore you make that movement more automatic. So that is one potential thing that you could do, but that could apply to any aspect of rehab. I'm going to strengthen somebody. Great. We know we need to get strength back. But there's certain ways that I can strengthen that really engage the motor cortex, and one of those being eccentric strengthening. And Lindsay Lepley has published a lot in this area. And when it comes to, I'm trying to improve joint sensation, let me think about the different types of receptors and how they affect things. And, a shout out there to Eric Wickstrom and Pat McKeon and their work. So we've been seeing a lot of this, and it's just having that moment to think about what you could do, or what the things you want to do are doing to the nervous system, and can they work better.
Awesome. So, what are some future directions of research or treatment, whether it's chronic ankle instability or the use of the transcranial direct current stimulation, that you're really excited about?
I mean, the tDCS has been, seeing just how many papers have come out in the past year on this. I'm like, wow, am I going to be able to keep up with everybody else? It's tough. But I think, so in our recent review paper a year ago, we talked about, having these motor strategies, having these sensory strategies, and having these integrative strategies to help improve motor function. But there's a fourth aspect of that, and that is this affective domain, this idea of kinesiophobia. There's been a lot that has come out in the past few years that have really drawn a link between not just kinesiophobia and symptoms of instability, but kinesiophobia and how the brain has changed and some of those neuroplasticity factors. Just kind of like where we were about 15 years ago, where we're like, oh, neuroplasticity. Okay, now what do we do about it? I think we're at that point now when we start to look at some of these psychosocial aspects. So I think, the development and the advancement of some of those psychological treatments and those affective treatments to improve readiness for return to sport and how that ties into how the nervous system remaps itself. I think that is probably one of the things that has me the most excited right now.
That's awesome. Really just integrating everything together.
We can't operate in silos, right? I think one thing I wanted to mention about my study that I hadn't come out with is, we did this study. We had just had somebody just sitting there doing TheraBand and balance. Would we have seen an improvement, right? It's just, we
Mhm.
can't look at anything in isolation. And that's the hard part about research, right? As researchers, we want to have experimental control and we want to really isolate these specific tools, but it's not clinically reasonable to do that.
Yeah. And then when we start to do things that blend everything together, you get the pushback of how can you truly isolate?
And
Yeah.
yeah, exactly.
Well, thank you again so much for joining me today. And just wanted to mention to everyone that Dr. Needle's work on transcranial direct current simulation, as well as some other manuscripts that he mentioned, are available open access through the Journal of Athletic Training. So, again, thank you so much for joining me today.
Yeah, thank you so much for having me.